I'll probably do it today though, because they're going to do this with the house.
But I have CCK meeting today.
Yeah, should be fine. It'll be a full one. I've got about 6 or 7 students coming to the evening classes from my other ones, so it'll be a full one, but we should be able to accommodate you. It shouldn't be a problem. Yeah. Return it. How about I put the projector? So we are at we're at week 12 this week. So this being week 12, right? We've got this lecture today. Next Tuesday, we have our Unit 3 exam. So on Sunday, I'll be giving a review for Unit 3. I say review, we're doing the Kahoot games like we usually do at 4 p.m. on Sunday. This Thursday, I'll give a review over, chapters 17 and 18 like I typically do. It shouldn't be real strenuous. If you have prepped for chapter 17 and 18, which is what we will be lecturing over today, you'll realize that chapter 17 and 18 aren't that bad. They're really not. There's the review of information. Chapter 17 is like taking what we know about immunology and applying it to when the immune system goes wrong. And then chapter 18 is mostly all stuff that we've learned before. There's 1 or 2 things that are new in chapter 17, or excuse me, 18, diagnostic methods and like putting them in categories. And then being able to put them in the categories is really what the main goal is of that. And then a couple of the new methods are new, but most of them we've already learned about in previous chapters. So we'll have that. What do I want to say elsewise? Does anybody have any questions about anything? So today is the 4th, right? So we know in 12 days is when your presentations are due. So just a reminder about that. If you are planning on recording your presentation, your recording must be submitted with your presentation on the 16th. You can't submit the recording later. So if you submit just your slides by the 16th, then I'm expecting you to present in person. There's not going to be any take backs on that one. Okay. So FYI. So it just depends if you're planning on doing a recording or an in-person presentation. Let me think. What else? Just making sure that we're keeping on track of stuff. Because I know like at this point in the semester, if we sit here, maybe you aren't affected by the issue with the SNAP benefits, but I can guarantee you there's somebody in this classroom that is, right? So whether they're saying it or not, or whether they come to me or I'm aware of it or not, isn't my business. It's not your business, nobody else's business whether they're affected by it, but are we going to see students, or maybe you are affected by this issue? And that's going to cause strain and stress on your life. Aside from other things that are going on in the world right now that might cause strain or stress in your life, and aside from whatever's going on in your personal life, that can cause strain and stress in your life outside of the classroom. So this is usually a time in semester, in a normal semester, where people would be very heavily at this point where we're like kind of struggling to stay afloat in the course. And we get a lot of projects coming up and then keeping up with your regular work and the other classes that we have going on and life. And now we have all this extra worry going on with stuff that's going on in the world right now. So if you're somebody that's having those issues staying afloat, keep in mind everybody's having these issues. So you're not alone in that. Number one, you're not alone. Number two, you're not alone. So that means that I am constantly getting emails about, can I join this later lab? Can I make up this lab? Can I do this late? Can I submit this late? Can I do this on a different day? Can I get an extension? It's pretty much like I am constantly getting bombarded with that stuff. And I am doing everything I can to accommodate that stuff. But keep in mind that I'm getting a massively unusual amount of requests, not just from this class, not you guys, all of my classes. A massively unusual amount of increase of requests for extensions, joining other labs, and things like that. So I will absolutely do my best to accommodate you. That's not the problem. The problem is that it's putting stress on me too, to try to sort out some of the schedules that are going on. So I need you to bear with me and have a little bit of grace with me. So like, if you come to me and you're like, hey, I asked for an extension on this, why haven't you done it? It's because I forgot, because I was dealing with sending other people's things or meeting with other people's whatever. And so if that happens, just shoot me an email. Or if you show up to another lab and you're like, hey, you said I could show up to the night lab, and you show up and I'm like, great. It's because I have like a lot of people having those requests in a lot of my sections. And I mean a lot. I want to say almost half of my hybrid class asked to join my night class, my night lab tonight. And it's fine. How many labs do we have left? Like 3. So it's fine. It's fine. We can accommodate it, but it's also, there might be a time now where I will say, I can't accommodate you and come into another lab because I literally don't have the seats because I have so many other people that requested it ahead of time. So just keep that in mind that we might have that going on. My night class, there's only 11 people in the class. So I can accommodate a lot of people. But like I said, I've got, I think 8 people now coming to my night lab tonight that are not in the night lab. That's going to bring it up to 19. So you can see how like at that point, I'm like, where am I going to put them? They can't all sit at their normal tables and stuff like that. So it starts ending up being a burden on me a little bit. So just keep that in mind that you might be one person asking for the request, but we've got a lot of people doing that. So again, if you ask ahead of time and I can accommodate it, then I will do my best. But it's like, if you end up being somebody that's like last minute, like, hey, can last minute do this thing? There might be a chance that I might not be able to. So just keep that in mind. The sooner you ask for accommodations, the better. And I will try to do the best I can to get you through the end of this course. If we are at a place in this course where we have a D in this course, this is me being real, okay? Just trying to be realistic with people who might have a D in this course at this point in time. It is unlikely you will pass the course. So I mean, is get it higher than a D. It's unlikely you'll get higher than a D at this point. So I just want to keep that in mind because Friday's the drop date, right? Friday's the last day to drop the course. So keep that in mind. If you're fine with that, then you're fine with that. Stay with it, stay the course, do your thing if you want to take the risk and possibly bringing up your grade. Is it possible to bring a D up to a C? Absolutely, absolutely. But you have to do more than you've been doing. So keep that in mind too. If you really think, yes, I can do more, I can bring it up, then I have faith in you can do it. But it's unlikely if you're doing the same thing. And most students do the same thing at this point in the course. So be realistic with that stuff. With yourself, because I don't want you to have to take the D and whatever. But there's another thing I want to say about that. The way that transcripts work is from now on at this university and within the OSU system, from what I understand, but definitely here. If you got a D in microbiology this semester and you retake it, because nursing requires that you get a C, right? So if you got a D this semester, and you took it again the next semester, it replaces the D. It doesn't keep the D, it replaces it if you got the C. So that's a good thing for your GPA if you're somebody dealing with that. So that D doesn't stay on your transcript, it gets replaced. And you can take classes up to 4 times, FYI, if you needed to do something like that. In your prereq classes, the nursing program has different rules about how many times you can retake classes and stuff once you get into the nursing program. It's a different rule. But FYI, that's a reminder about that. Again, just reminding about it because the drop date is Friday. So be realistic with your situation if you feel that applies to you. One last thing that I want to say as we're coming up on the end of the semester and we're just trucking, man, we're just trying to make it through. Me too. Okay, I want to be clear about this. Me too. Is with the lab stuff. In lab, if you miss a lab, let's say you slept in or you were sick, but you didn't go to the doctor because you didn't want to pay for the doctor's visit or whatever. You missed the lab, but you don't have a verifiable excuse for it, right? If you don't make it up with another class, like if you missed our Tuesday morning, like today's lab after class, missed that lab, you could go to my night class just fine. You don't need a doctor's note to join that. Just email me and make sure I have the spot for you. That's fine if something like that happens. This is moving forward too, okay? I don't have a problem with that if you ask me if you can make up the lab at one of my other active labs, which for this class, again, typically is going to be the night lab, okay? Or if you know ahead of time, you're welcome to join a Monday lab as well, or Wednesday, depending on the day, right? So keep that in mind. However, if you miss a lab, you can't just get your data from your lab mates. So I want to keep that clear too. So there seemed to be a little bit of confusion from that earlier in the semester and a little bit continuing on a little bit. So I just wanted to clarify that if you miss the lab and you don't have a verifiable excuse, you can't turn in the lab for points. There are a couple instances of that where I missed. If I gave you points in an incident like that, then it's fine. That was on me. But if I caught it and I said, you can't have the points, you can't have them. If you weren't in the lab and I caught it, you don't get the points. You can't just get the info from your lab mates and fill in the sheet or, get a copy of their sheet and submit it. So I just wanted to say that unless you have a doctor's note, and that incident, I am letting people do that. So that's like, I think where a lot of the vagueness or confusion came from. If we had a student that had a doctor's note, they could get the data from their lab mates. But if you don't have a doctor's note, then I cannot allow that. Okay, is that clear? I just wanted to clarify that a little bit moving forward, because again, this is that time in the semester where I have a lot of spottiness. We can tell this is supposed to be a full class, right? So, and so we're going to have this situation pretty commonly for the remainder. We have 4 people online, so we do have that as well. So, it is what it is. Okay, so I don't want to do this. What I want to do is 17. Okay, any questions about any of that stuff? All right, let's get logged into this so we can get cranking with chapter 17 and 18. Today's lab, I know I say a lot that labs are going to be short, but pretty much you guys really showed up whenever I asked you guys, like, hey, let's pay attention, let's crank through this last lab. I don't want much lollygagging. And you guys really showed up in the last lab and we really cranked it out and you did great with it. But I will say, moving forward, other labs are going to just be quicker. And so that was the longest, most complicated of all the labs that we have left. And you did it. You made it through early. And so I have all the confidence in the world that these other labs that we have remaining, especially today. My other classes took less than an hour for today's lab. And it's a 2-hour lab. So
You say that and it makes me worry about the attendance.
So yes. But there is that. But we know too, we're kind of noticing that doing the labs for these labs, it's not a lot of work to do the labs, but the content within them, and that's the issue, right? So that's the thing, is that the content in those labs, there's a lot of content behind it, but the doing isn't a lot of doing. And so that's why the labs are faster, but there's more content behind them. And you're probably starting to realize that as we're cranking through. And so that's, yes, so should you worry about the lab exam? It is not easier than the midterm. It's actually more info, right? Because we have some midterm info and we have all of this new, like, what does yellow mean in this situation? What does yellow mean in that situation? What does pink mean here? What does pink mean there? And all of that going on, where it's a lot of info to sort out. And so as you're preparing for the lab exam, it is a lot more information. I feel like a lot of the lab exam stuff, a lot of it does blend to flashcard type stuff on this lab exam. That's just sorting out the colors and what they mean and stuff like that. So if you're finding that, like, hey, I feel like I'm doing a lot of flashcard type of work, like I said, memorizing and then recalling type stuff on the lab exam, then that's fine. But just keep in mind that don't just memorize the results, right? Also have some context into what the colors actually mean and what they represent and what's going on with the bacteria.
Would it be helpful to like memorize the dichotomous key and then with the colors that go with each?
I feel like that's a lot more work than you would need, yes. So the dichotomous key, so we will have the dichotomous key. I'm gonna give it to you guys. Has it opened yet? I don't think it's opened yet. Has
It's
it?
just in our prelim.
Yeah. So, yes, so our dichotomous key that we'll be using to identify our organisms, we have one specifically for our organisms that I will be opening up within that unknown lab exercise soon. And I do have it available if anybody wanted to look at them. It's not like it's like against the rules to look at it. And, you know, we kind of showed it a little bit in lab, right? There's no reason to memorize that one because I will hand it out on questions where you need to use it. So there's no need to memorize that one. But having context for it isn't a bad idea, right? It's not a bad idea. So you could look even at the dichotomous key and say like, okay, if this organism is positive or negative for indole, but what does that mean to be positive or negative for indole? What test did we perform to test for indole? We haven't gotten to it yet, by the way, if you're confused about where that came from. But which test did we perform? What reagent did we use? Does it have a pH indicator? All of that stuff. So you could start looking at it as like a reference point to see if you understand the test and how they're used. There's no harm in that, but you don't need to memorize the whole thing. Okay. Yes, question.
On the pre-lab, I've noticed sometimes with the dichotomous key, that there'll be the 3 microbes that we're kind of zeroing in on.
Mhm.
And two of the 3 will be over on one side where they're clearly doing that one path. And then the third one over here, and then we'll do that first test. And it'll put us over on the side which just has the 1 microbe. Would you still continue down the path just to confirm it? Or would you stop right there?
If it still has other questions for it, then like this is, so in real life, in a dichotomous key,
Yeah.
like this is, it's just simplifying it for you, really is what it's saying. It's like, okay, you're going down this path. You would still continue the other tests that would be associated to it because the only reason we would have other tests is because there could be other microbes off of the other test.
Okay.
Normal situations won't have like, you're going straight towards E. coli and there's like 5 tests up just to E. coli. It wouldn't make sense in real life. So in real life, if we have other branching, it'll be because that branch could lead to 2 other choices. Yeah,
So it's not really realistic to say, okay, I've only got 3 here.
right. Mhm.
Okay.
Yeah. So, and you'll see that on our dichotomous key that I hand out for our thing. It's much more simple. I feel like it's clearer. And again, if you want to see it when we get to lab, I have them.
Well, it's not that it's not clear. I'm just curious if you would have skipped those other steps, but you answered my question.
Yeah. They're usually there for other microbes, but they're just not shown on the thing. Yeah.
So in the scenario, you tell what the organism is the microbe you're looking for. And
Well, in the scenario, what I'll do is tell you that you have a microbe that is positive for urease, negative for indole, didn't grow on staph media, was gram positive, it was a bacilli, and it made gas and glucose. And then I'll give you a key and you tell me what the organism
So
is.
you just follow.
Mhm.
That's-
It should be easy, right? It should be
So
that
I
easy.
don't need to worry about the dichotomous.
No, you shouldn't have to, right? And so
Okay.
for some people that are picking up on this, that are looking at this and they're like, oh yeah, that seems easy. It really is meant to be that easy. But I'm telling you, other people that haven't looked at the dichotomous keys and actually tried to use them yet are like, what are you talking about? They're just
I
not
was
letting
so
you know that
stressed
right now while they're sitting in this class, but I promise they're sitting in there thinking this, okay? So that's the thing. So if you want to see it too, and I'll show you it, and especially like, I don't remember if you guys, because I think that you guys at table 6, I don't think we can identify any of your organisms straight up, but you'll see the route that you're following. And then you'll say, oh, I just have to do this test and it'll show me what my organism is. And you'll see what I mean. Yeah. And so, yeah, I think that'll clarify some of that. I mean, it'll just affirm what you're saying there. And then it is really just that easy. It's just like, was it positive or negative for this test? It was positive. I go down this way. Was it positive or negative for the next test? It was negative. I go down this way. And it really is that simple. And so on the exam, I might give you a whole chart, like the ones that we're making for the lab right now. And it'll have a ton of info on it. And then the first question is, did it make gas and glucose or not? So you find the glucose on the chart, see if it made gas or not, and then follow the route. Make sense? On another question, I'll just list some results. It's not gonna be in a chart form, but what's the difference? There's not really one.
You just gotta work your way
You just got to work your way through the dichotomous key and find the info in the paragraph, the same way that you would have found it in the chart. That really is that easy. All right, we ready? Let's do chapter 17. Again, this is disorders in immunity. So whenever things in your immune system are doing things that aren't fighting a bad guy, but doing something that could become harmful to you in some way. This is when our immune system is doing stuff that it shouldn't be. My next office hours. Okay, my next office hours are today from 1 to 3. And then tomorrow, 9 to 11. And again, from 3 to 5 tomorrow. So those are my next office hours. Thursday is from 9 to 11. So that's all that I have this week. So after lab, basically, I will say that after lab will be my office hours. All right. So again, here are our learning objectives for chapter 17. We know that we have our learning objectives. Let me see here. Yes. Okay, we know that we have our learning objectives for each of the chapter. Just a reminder one more time, the goal is while you're studying to get your info in place to where you can actually answer all of the learning objectives. And I say it every time, but I just really want to drive it home. Be able to answer the learning objectives without having to refer to your notes, recalling that stuff and being able to have a conversation about the learning objectives without having to refer to your notes. That's the goal of when we're studying. Okay, FYI. If you do that, you'll be more than well prepared for the exams. All right, so immunopathology. This pathology has to do with disease. So this is disease associated with the immune response, okay? This is overreaction and underreaction. So reacting to self when you shouldn't be ever attacking self. Reacting to antigens that aren't harmful, like allergens, stuff like that, or reacting to other people's molecules, if like I give you a kidney or something like that. How is that actually helpful for your body? It's not. It's not beneficial at all, but this is not something that is really basically regulated well in the case of these immune diseases. We also have immunodeficiencies, which are hyposensitivities. This is underreaction to something that might actually be harmful. So those are the other sides of the coin. All right, so we'll have our hyposensitivities and our hypersensitivities. We'll talk about the hypersensitivities first. So this is type 1, 2, 3, and 4. And all of these guys are kind of overreactions to situations and basically different types of immunity, which we'll get into what causes them and what they're related to. You will definitely need to know the general basis behind each type of hypersensitivity, as well as the general basis behind primary versus secondary immunodeficiencies. So,
General, what are you?
we're going to talk about it. Okay. So we're going to get into it. So I'll tell you what it is. Yes. And so we're going to get into each one, because if I sit here and tell it all at once, then it's just a bunch of blah, blah, blah. And then we'll have slides that come with it and I'll clarify it. And so primary immunodeficiencies and secondary immunodeficiencies, we'll talk about those as well. The basics on those, because those are easy to just state kind of what they are. A primary immunodeficiency means you have it from birth. It's genetically related. And a secondary immunodeficiency means you acquired it later in life. Obviously, acquired immunodeficiency syndrome, which is AIDS, would fall into the secondary category. You acquired it after you were born. It's not there from the beginning. If you get cancers like leukemias or lymphomas that affect your immune system, that's acquired later in life. Okay, that sort of stuff. Exposure to radiation, exposure to certain chemicals also can lead to that sort of stuff. But primary immunodeficiencies usually are genetically related immunodeficiencies. You were born with some sort of mutation or something like that that led to your immunodeficiency. So let's talk about these hypersensitivities first, okay? This part down here, Kristen, is what you were asking. So the general idea of what causes each of them, type 1, type 2, type 3, type 4 at the bottom down here, that's what I mean by the general basis of how all these are governed. So hypersensitivities can be triggered from outside allergens or antigens. I should just keep it as antigens. Outside antigens or inside antigens. Inside antigens means it came from self. So that would be our autoimmunities typically. So our endogenous would be our autoimmunities. Our exogenous, we're reacting to something that came from outside of our body. So many of us will be, many of these will be talking about stuff that came from outside of our body and that relationship. Type 1 hypersensitivities are triggered from IgE-mediated reactions. So if we remember, when our immune response happens, we had to activate our T helper cell first. right? So we had our T helper cell with our outside antigen. Let's say it's dog dander, okay? You're allergic to dogs. It gets into the body. We had to find the T helper cell and activate it first with our macrophage or whatever, found the T helper cell. The T helper cell helped activate the B cell that sees dog dander. And the B cell was activated. It made the antibody against dog dander. It made IgM first. IgM was first. We recognized it on the surface of the cell with IgD as a receptor. And then we were activated and we started producing IgM first. For some reason, there were signals that told the body we needed IgE. So we class switched from IgM to IgE. That's what happens in allergy responses. So anytime you get hives, itchy eyes, nose, ragweed, most eczema, asthma or anaphylactic responses, those are all mediated by IgE being made against an allergen. It's an antigen that was non-threatening for some reason, and we just triggered IgE to be made. So just due to the signaling that's involved in it. Now, normally IgE is going to be made in response to parasites, protozoa and helminths. For whatever reason, the body got signaled to treat dog dander or cat dander or mold or whatever like a parasite. Got the signals for that. So that's what drives allergies. That's the type 1 response. So this can be atopic, which will be local stuff, or anaphylactic, which is a systemic response. Okay. Type 2 responses. These are almost all blood type related, either ABO blood group or RH, which is the positive or negative of our blood types. And so we can see those as foreign if we haven't seen them in our body before. We'll talk about the details of that. But basically, the way that I would see, so I'm A positive. So the way that I see B blood, that looks foreign to my body. So I have IgG and IgM against B blood naturally in my body. It looks foreign to my body. I've never seen a B. What the heck is a B? I don't need it in my body. My body makes IgM and IgG against B. Now, if we remember back in chapter 15, we learned about complement-mediated immunities. Those blood proteins in your blood that get activated like bombs and then cause a cascade reaction. And that can lead to opsonization, inflammation, and the membrane attack complex. So what happens is in the classical pathway of activating complement, which is using antibody binds to something, it causes a bomb to explode, which causes all the other bombs to explode, and etc. Then the parts of the bombs come together and poke holes in the target cells. Except in the target cells in this case is the blood that's not the self blood. So complement is poking holes in the B blood in my body if you give me B blood. That's a problem because we'll start poking holes in blood cells, even though they're not mine. If I start poking holes in B blood that was transfused into my body's going to be like, why is there blood cells exploding everywhere? Now my spleen is responding to that by trying to filter out the destroyed blood cells. And my body is getting all this information from those exploded blood cells of like, hey, we're exploding blood cells in here. And then you go into a shock response and you almost always die. It's extremely common to die from a blood transfusion that is not your right blood type. So that's a huge issue, right? We want to avoid that as much as possible. That's type 2 reaction. Complement-mediated cell lysis, governed by IgM and IgG against blood types. Typically, it's blood types for this one. Okay. All right, this can happen if I'm getting the wrong blood type, but it can also happen if you're a mom carrying a baby that is a blood type that is seen as foreign in your body. We'll talk about that as well. Okay. This is just the teaser to get into the ideas. Okay. We'll talk about the specifics in a moment. Type 3. When antibodies bind up to antigens and we cause them all to stick together, like the agglutination thing that we were talking about, this creates immune complexes. So here we have IgG that is like basically binding up with bacteria or parts of bacteria or viruses, and they create these immune complexes that typically, when antibody binds with an antigen, our macrophages and neutrophils will eat them up and get rid of them. And that's opsonization, right? We learned about opsonization. We'll get rid of them that way. But some of them, the medium-sized ones, the leftover ones, get stuck in our capillaries, in our joints, in the tight spaces in our body. And then the neutrophils try to attack in the area and keep releasing inflammatory responses in those tight spaces. And that leads to the type 3 type of reaction. We'll talk about examples of that, but one obvious one is rheumatoid arthritis. So we get these immune complexes stuck in the joints And that leads to inflammation in the joints because we're trying to get rid of the immune complexes. Another obvious one is lupus. We get immune complexes stuck in the capillaries of the skin. We get that butterfly rash that's associated with lupus. Okay, so those are two obvious examples. We'll talk about another example when we get to it. Type 4 hypersensitivities. These are immune responses that are governed by our cytotoxic T cells. So remember, those are the cells that go out and kill infected cells. MHC1 mediated type stuff. When you get a cytotoxic T cell memory, so we've attacked flu cells that are in the lung, or flu infected cells in the lung, and we created our cytotoxic T cell memory. If we see that strain of flu again, we'll reactivate the memory. But the memory T cells, do we keep up like millions and millions of memory T cells? And we keep a few of them. But if the T cells are the ones that do the work in the T cells, then the memory cells have to repopulate again. And so that's why it's delayed. Memory B cells can crank out IgE or IgM or IgG immediately. You don't have to multiply out the cells to do that. But T cell memories have to multiply out the cells for them to actually start acting. So it takes a couple days. You know this one better than you think you do. This one is what governs the PPD skin test for tuberculosis. Tuberculosis is an inside the cell infection. And so you need T cell response to kill infected tuberculosis like lungs cells, okay? And if you've had tuberculosis, you will have had a T cell response to it, and you'll have the memory. So when I put the tuberculosis antigen just under your skin, the T cells will get reactivated and in a couple of days populate and cause the welt that they're looking for whenever you guys go get the test at the hospital to see if you've reacted to tuberculosis. If it welts up, you have memory T cells, but it takes a couple of days. There are other reactions that are governed this way as well, and we'll talk about them when we get into them. So those are us dipping our toes into these types of hypersensitivities. There's more to them, and there's more examples that we'll go over when we get into them. Any questions off the bat about any of this stuff? Yes.
On that type 4, taking time to ramp up to produce enough cells, specifically what kind of cell is it?
Cytotoxic T cells.
cytotoxic
With CD8.
CD8?
Yes. The CD8 cytotoxic T cells. And so those are usually ones that are going to mediate it. And then when they start acting against things, they'll activate other cells nearby, and like macrophages and stuff like that. Now we've seen this because when you have an allergy to something like cats or whatever, you get itchy, you get hives, your eyes will swell up, you'll have a little bit of weepiness and runny nose. That's our histamine response. That's governed by IgE, right? That's the type 1. But if you get poison ivy, you get that blistery, weepy, damaged skin that's going on. That's type 4. So our cells, our T cells, are attacking our own cells and killing them, causing damage to our own cells in those types of responses. It's different. If you go roll out in poison ivy, do you immediately start getting the rash? No, you get it a couple days later.
I have
Yes.
a curious question. So I don't get poison ivy.
Mhm.
Why? I mean,
You don't
I'm
get
not
poison
really-
ivy. You don't get poison ivy because your body was trained to see poison ivy as not a danger. My body was never trained to see poison ivy as not a danger. It's just during your training response. That could have been whenever you were very, very young. You got exposed to the poison ivy and your body was like, this is not a threat. We're good. Get rid of it. It's also possible
Because
that,
everyone else in my family goes into like anaphylactic shock.
Mhm. yeah, almost everybody is, right? Most people are. It's actually very rare not to have a response to poison ivy. And so with poison ivy, it just means that your genes reassorted in a way, right? Remember, we had like you select parts of the gene, you put them together, you add or delete nucleotides, and yours reassorted in a way that your body was able to say, oh, poison ivy is not a threat whenever we were training your body, or they reassorted in a way that we never saw poison ivy. We just don't react to it.
To the hygiene.
And that can relate to the hygiene hypothesis, which we're going to get into in a little bit. What?
Class 3, you have to have some kind of invader, so to speak, and then that stuff. So something happens and then while your body's fighting it off, something gets like crammed down in those spaces. And so that's where it comes from.
Typically,
Okay.
typically, but we can also see stuff that way. So self antigens. So parts of your own body can be seen that way, and we can create complexes to parts of the own body. Now, usually that's triggered from having seen something foreign that looked like self. Called molecular memory. No,
Okay.
So it could be.
So that's type 2,
exogenous
remember,
or-
she's asking about type 3.
So it could be exogenous.
Yes, all of these typically can be exogenous or endogenous, all of them can. So we talk primarily about the exogenous, but we need to keep in mind that some of these can be endogenous as well. So an example of a type 4 hypersensitivity that's endogenous, where your own T cells are attacking your own cells, is type 1 diabetes. Diabetes, where your own T cells killed your own pancreas cells. That's type 4 hypersensitivity. So that's an endogenous antigen there. Make sense? Okay, so let's get into these. We'll get into more specifics on each of these as we go. All right, allergies. Again, type 1, so we're in type 1 first. Let's stay there. These are our allergies. Allergens are things that we see as foreign, but they're not a threat. So for whatever reason, the body is still creating an immune response to them, but they're not really a threat. And usually we've gotten signals to switch to IgE response with them, okay? You always require in type 1, 2, 3, and 4, okay? We usually have to have some sort of sensitizing event where first we saw the antigen, then we started making antibody against it, and now we have the memory cells to it. Okay, type 2 is a little more complicated than that. We're not going to get into why that's complicated, but it's a little more complicated than that. But anyways, so with the type 1, you had to see dog dander and then activate your T helper cells, activate your B cells, make the IgM, then switch to IgE. That takes like a week or two to get all of that cranking. So your first time that you ever saw dog dander that you were going to be allergic to, your body had to do all that first. So you didn't have an allergic response the very first time that you saw it. The second, third, fourth, but every time after that, you'll have the allergic response. This is why you can get stung by a bee the first time and be fine. And the second time, die of anaphylactic shock. Because you had to have the sensitizing dose first, okay? So if you've ever been stung by a bee, which is not common, right? But if you've ever been stung by a bee and you were fine, and now you think, I'm not allergic to bee stings, but that was the only time you were stung, you're not safe. You can die the next time you get stung. So you've only had one sensitizing dose, and you haven't seen it a second time. You don't know yet. That's the facts. Okay. All right. So this is all based on a sensitizing dose that activates production of IgE. Every time after that dose will activate your allergic response. And this can be local or it can be systemic. Obviously, with bee sting, I'm talking about systemic, right? That's a systemic response. Your whole body is having the reaction at once, and that leads to anaphylaxis. However, if you have allergic to cat dander or dog dander or mold, or you have hay fever, those things are atopic. Those are local. They're relatively like confined in an area. Your eyes and your upper respiratory tract, for example. If you have asthma, your lower respiratory tract. If you have eczema, your skin. Those are not systemic. Those are still just allergy responses. Atopic is what we call it, atopic. Yes.
So even after after the first time you're stung by a bee, will you still produce the IgE as a reaction?
Yes. So yeah, every time after that, you'll produce IgE. And it'll just get reactivated. And we're even like solidifying that type of reaction every time that we see it. Okay. So again, atopic is chronic local allergy response like hay fever and asthma. Anaphylaxis is going to be systemic. And what happens in anaphylaxis is we are triggering release of histamine and bradykinin and all of these things that get released by our granulocytes, specifically our mast cells. Instead of releasing it in the tissues in the area like we see with like hay fever and whatever, we're releasing it in the bloodstream. And then that's causing mass collapse of our circulatory response, a significant decrease of blood flow to the brain and the extremities. And it can be so severe that like you cut off enough blood supply to your extremities, you can't even get epinephrine from your muscle to your heart to reduce the response. And then no EpiPen is going to save you if it gets bad enough. And that's what we have to give cardiovascular epinephrine at that point. We'll talk about that when we get to it, okay? You guys will learn a lot about this in your nursing or vet school whenever you get this. Because can dogs and cats have allergies? Absolutely. So keep that in mind if you're going into vet school. This also applies, okay? Okay. Yes. Same. So me too. So with cats, I'm that person too, where I have to, if I'm going to somebody's house that has a cat, I have to take like 5 Benadryl before I go. And I mean, it's like I load up, like I'm barely functioning, but I love cats, but I'm really allergic. And if I go to somebody's house, like I'll go stay at your house for like a weekend. If you have a cat in your house, you can clean all you want and put your cat in a separate room. I will almost always not make it past one night. I'll have to leave your house because my eyes will close up, my throat will close up. I've had to go to hospital just from being in a house that had a cat that they didn't keep it clean enough. Like it's that bad. So I'm with you here, man. It's me and cats. I like cats a lot. Some cats, and I'm sure you guys know this too with your allergies. Some cats I'm more allergic to than other cats. Just depends on the cat. Yes, it depends on the cat.
It's like a protein in their saliva or something.
Mhm.
It's not like,
Yes,
I
it's
was
their.
looking at the vet clinic and I was like, I'm allergic to cats. And he's like, then why are you here? And I was like, I'm only allergic to some cats, but it only like makes my arms super itchy and my nose start running.
Mhm.
But that's,
Yes, yes. Yeah,
and it's not all cats. It's so weird.
yes.
We used to take vets, like, are you allergic to this one today or not?
Yes, and so it was like that. So I used to work at, I used to volunteer for the Humane Society. It was the same thing. Like they would be like, hey, you're gonna clean the cat room. I'm like, great. Like we're gonna, I'm gonna take all the Zyrtec and all of the Benadryl, and I'd have to stay loaded up on it the whole time just to keep at a place where I could function. And I did it because I like cats and I wanted to help, but I don't own a cat. The other thing is you can become desensitized is what I should say. You can become desensitized to a cat or a specific animal. So when I was in graduate school, my friends got a cat and I was allergic at first, but gradually over time from being exposed to that cat, I stopped being allergic to that cat. And it could sleep on me and cuddle on me and everything, that specific cat. And so if you're exposed to an allergen as well, we'll talk about desensitization as well. In that case, did we stop making IgE? No, but I'm gonna tell you what we did do. We started making IgG. So if we make IgG, which is always made in a higher like percentage of your blood, like if you're a B cell, if you're making IgE, you're gonna make a little IgE. But if you're a B cell that makes IgG, you're cranking that sucker out and you're gonna load the body up with IgG. Now all that IgG binds to that cat standard, so the IgE can't get activated. So the IgE is still there, but it's like in such small numbers. The IgG is getting rid of all the allergen before you ever stimulate the IgE. So that's how desensitization works. It's just using a different antibody to block the action of the other one. Okay, so good stuff. So the idea with allergies is the hygiene hypothesis. The hygiene hypothesis says we are so clean that we're not getting exposed to enough antigens to properly train our body of what is a threat and what isn't. So for example, first world countries, we have high incidence of allergies, whereas in third world countries, you have extremely low incidence of allergies because they're exposed to the parasites and their body gets trained that IgE and eosinophils are for parasites. Folks, in like America and in places where we have high levels of hygiene, you don't see the parasites, your body is less likely to be trained properly. Now, if you grow up on a farm or something like that, you're less likely to have allergies. If you grow up in the city, you're more likely to have allergies. Again, because in farms, we're exposed to, you're playing outside, you're seeing all these different allergens, you're getting exposed to all this stuff. We will probably see that shift as society has turned from having the kids go play outside 90% of their life and get locked out of the house like they did when I was a kid. Like I lived my entire life outside. My parents were like, oh, it's light outside. Go outside and lock the door. And that was it. They didn't see us again until it got dark again. And that was every day of my life. Yeah, don't come bother mom. We're here in the house. We don't need the kids here. If it's nice, if it's light out and it's not hailing or tornadoes, you're outside.
Don't come back to
Don't come back until yes, once the street lights come on. So that was how it was, right? But today's kids, right, most of them are inside all the time today. And so we will see an increase in allergies in the newer generations as they are less and less exposed to that stuff. So that's the idea of the hygiene hypothesis. Okay. All right. So what does the hygiene hypothesis propose? Some of this stuff is true statements, but is it the hygiene hypothesis? All right, exactly. Good job, guys. So the lack of exposure to certain microbes can lead to development of allergies because we're not training our immune system with them. Beautiful. All right. All right, so there's different types of allergens. We know this as well. It could be things that you inhale, ingest, contact, or inject. So it just depends, and depending on the type of way that the allergen is delivered can also trigger atopic versus anaphylactic responses. So that can be the thing too. So you can ingest drugs, but you can also inject drugs. And then you might have an anaphylactic response if you inject it, but might have a atopic response if you ingest it. For example, can you have anaphylactic responses to things you ingest? Absolutely. You can have anaphylactic responses to inhalants, ingestants, injectants, and contactants. But you also can have atopic responses to those things as well. Just depends on that person's body and how their immune system is reacting to it. Okay. It's different from person to person. There's no hard and fast rule about this stuff. All right, so here's the idea of how this works. The allergen gets into the body. Let me get my pen here. I always forget. This would be easier if I could just draw this out. In step one, the allergen gets into the body. Our T helper cell gets activated from the allergen. It activates the B cell, which then becomes a plasma cell, making the IgE. That's our sensitization event. We make the IgE. In the interim, the IgE studs a mast cell. This is what really like drives the whole response, is this right here. IgE gets camped out on the surface of mast cells. And those mast cells will like stay stuck in the tissues, in your skin, in your lungs, in your upper respiratory tract, or even just hanging out in your whole body, okay? Then the next time that you see the allergen binds the IgE that's stuck on the surface of those mast cells, and those mast cells degranulate. What does degranulate mean? It means it releases all of their signaling molecules for inflammation. So IgE plus the allergen, which is the antigen in this scenario, leads to mast cell degranulation. What types of molecules are made during the degranulation? Well, histamine, that's one of the major ones. You guys know that one. Also bradykinin and serotonin and other things that are involved in the inflammatory response. Pro-inflammatory cytokines. Pro-inflammatory. Makes sense? Any questions about that process? So it relies on IgE causing mast cells to release those mediators. Okay? All right. So you could block the IgE. You could block the allergen by binding it with IgG instead. You could block the production of the IgE. You could block the degranulation of the mast cells, or you could block the action of those mediators. There's a lot of drugs that can act in any of these steps. We'll talk about some of them in a second. All right. So again, IgE primed mast cells will degranulate when we see the allergen. Let's see. Which antibody is it that's associated with this? Hopefully I've said it enough times. Type 1s, type 1 reactions. Which antibody? All right, beautiful. Yes, IgE. All right, so hay fever and asthma are atopic responses where we have our mast cells either in like the upper respiratory or the lower respiratory, respectively, okay? So in hay fever, we also call allergic rhinitis. Okay, basically moving forward, we're gonna hear itis a lot from here until the end of the semester. Itis, something itis, something itis, something itis. We're gonna see rhinitis, we're gonna see encephalitis, we're gonna see meningitis, we're gonna see vaginitis, we're gonna see itis, dermatitis. If you see itis, it means inflammation, always. So if there's actual inflammation in the response, itis. You can have bacterial infections that don't stimulate measurable inflammation, for example, and we call those osis. So if there's not measurable inflammation, then it's osis. If there is measurable inflammation, there's itis. So you can get measurable inflammation from infections, but also from other things as well, right? Okay, so I just wanted to bring that up. Arthritis, for example, your joints are inflamed. Is that from an infection? So it could be type 3 if we're talking about rheumatoid arthritis. There's other types of arthritis too, right? It could just be from friction and things like that. Improper lubrication of the joints. So it might not even be necessarily like immune mediated, but the inflammation that results as a result of it is still immune mediated, right? But it's just like secondary to the effects. Okay, so itis, we have inflammation. Here, allergic rhinitis is inflammation of the rhino, which is the nose. Beautiful. Okay. So we'll see that a lot, and I'll have a lot of stuff like that. So if we talk about meningitis, we have inflammation of the meninges, which is the covering of our nervous systems, the covering layer of our nerves. If we talk about encephalitis, it's inflammation of the encephalo, which is the brain itself, the brain tissue itself. We talk about vaginitis, inflammation of the vagina tissues.
Well, it's water on the brain.
Yes, so that would be hydrocephaly. Hydrocephalus. Yes, hydrocephalic, yes. Yes, so now you guys get this, right? Now we're getting to, when you guys, if you haven't taken med term, I highly recommend taking med term, because all of this will be so easy for you. You won't even be thinking about it. You'll know the parts of the words, the prefixes, the suffixes, the root words, all of that. You know the meaning of that stuff. That's what med term does, is it teaches you that. So if you haven't taken it and you still have some credits that you need to take for that, I would highly recommend med term. It's an 8-week course. Knock it out, man, if you need it. Raise your GPA if you need it. I don't know. If you don't need it, then do you? But if you talk to Dr. Rhodes is the one that teaches that. He teaches that. So we have adjuncts that help with him, but he's the one that runs it. And he's excellent. So eczema. Atopic dermatitis. So again, atopic, local, it's just going to be in the dermatitis, inflammation. So it tells you stuff about it, right? So there's that. So eczema is also known as atopic dermatitis. We have a sensitization through ingestion, inhalation, and occasionally skin contact. So I'm going to point that out. Eczema is not usually triggered by contactants. So creams, lotions, whatever, aren't usually what triggers eczema. It's usually things you inhale or ingest. You can also have the inflammation of eczema associated with the stress response, which I do. I get eczema from stress. Guys, my stress leading to inflammation in my body is unreal. I get pancreatitis from the stress. I get eczema from stress and all of that stuff. So your stress response, your cortisol release, can actually trigger the inflammatory response that can lead to these things. Is that a type 1 reaction? No. But is it inflammatory? Yes. Okay, so FYI. But yes, eczema is one of these that can be triggered by a lot of different things. Yes, so, and that's one of those things that you really have to, that you usually have to go to a dermatologist or an allergist in order to figure out how to manage that stuff. It's not easy. It's not as easy as it seems like. Using steroid creams is a way to deal with the symptoms, but it doesn't get at the cause, unfortunately. Okay? I can tell you from experience. All right, food allergies. Ingestants and things like this. You can have GI symptoms, but you also have other symptoms in the rest of the body. So you might have hives, you might have skin rashes, you might have other anaphylaxis even from ingestants. It just depends on the allergen and how it's triggering the pathways. For example, I'm allergic to whey as well, whey protein, and I still eat whey, and I have very mild symptoms, but it is an allergy, and I'll even get inflammation in my gut that you can see in a colonoscopy and stuff like that as a result of my allergies to whey. But I'm like, it's worth it. I'm not going to stop eating cheese, you guys. Cheese, I'm not giving it up. Okay, it's not happening. This is not lactose intolerance, an actual allergy to the whey, because my body sees whey, it's foreign, and so I have an allergic reaction to it. All right, so drug allergies, this can be ingested or injected or topical application, anything like that. You can have anywhere from a mild rash to fatal anaphylaxis from this. Most common drug allergies, xylins, anything derived from penicillin, right? You can be allergic to all of the xylins all at once. Sulfa drugs, you'll be allergic to all of the sulfas all at once. Aspirin is actually pretty common to see aspirin allergies. So we call these salicylates. You've heard of it, salicylates. These are any drugs that are related to aspirin, including salicylic acid, acetyl salicylic acid, and all of those things are this. And even like Pepto-Bismol. If you're allergic to a salicylate allergy to aspirin, you're also allergic to Pepto-Bismol, which is bismuth salicylate. Opiates, any of the opiates you could be allergic to, and then contrast dye using X-ray. These are drug examples that you could be allergic to that are commonly seen. There are other drugs too, but this is the most common ones. Systemic anaphylaxis can be triggered by any type of these allergens, but more commonly associated with injectants, more commonly. And bee stings, that's an injectant. You're injecting it into that person's body. So the bee is doing it, but still, bee stings. And this will lead to systemic response. So if we're sending out the signals in the whole bloodstream throughout the whole body, that's what anaphylaxis is. Not local. So when we treat allergies, we usually are going to reach for anti-inflammatory type drugs. We can be antihistamine specifically, which is one of the signaling pathways of this, or it could be like general anti-inflammatory. Now, we've talked that there are benefits from inflammation because they have a role. It has a role in fighting things. So if you are on any drug that is like general anti-inflammatory, you will have reduced immune response, period. An example of this is steroids. Absolutely, under no circumstances should you be taking a steroid if you don't need it. Number one. Number two, never for long periods of time. Number three, there are diseases where you will get put on steroids for long periods of time and watch how those people suffer. It is really bad for your body to be on steroids for long periods of time. Your body is not meant to have your inflammatory response suppressed for that long period of the time. Okay. All right. So our oral anti-inflammatory drugs or are injected or are infused. Okay. For example, there are some drugs that literally block inflammatory signals like our cytokines like TNF alpha, which is tumor necrosis factor alpha, which is one of our cytokines that just signals for inflammation. There are antibodies that you can take, literally like you get them injected in your body or infused into your body. Antibodies that literally block tumor necrosis factor from binding to its receptor. So you stop that signal pathway. It's great for people that have inflammatory disorders like autoimmune diseases.
Is that what Humira does?
That's what Humira does. That's literally what adalimumab is. Adalimumab, which is Humira, is a monoclonal antibody. That's what mAb means. If you ever hear a drug that says blobbity blobbity mAb, mAb means monoclonal antibody. It's an antibody that's made to usually block some signaling pathway in the body. In the case of Humira, it blocks the inflammatory signaling pathway. And that's why if you're on Humira, you are susceptible to infections, especially parasitic infections. And so, yes.
They wanted to put her in there after she went through.
And you will see, yes, and you will see that people who are on these drugs almost always have opportunistic infections. It's just a matter of what you're going to weigh with the risks, the benefits.
That's what she does.
Necrotizing fasciitis, because her body couldn't fight it off from the beginning.
Well, she doesn't take Humira, but she doesn't take the like 15 years RH meds, which lowered her immune. That's what she does.
Wow, yeah, yeah. So that gets really complicated then with the immune system. It's all related to that and dampening the immune response. All right, so antihistamines are a little more targeted. They're usually only effective against atopic allergies, and they take a while to kick in. Most antihistamine, if you do it as an inhalant, like we have inhalants that you breathe into the lungs or into the sinus cavities, those will work faster because they're acting locally. But if you take a drug like Benadryl pill, it's going to take 30 minutes for the body to process it and send it to the area where it's going to be effective. Some antihistamines cross the blood-brain barrier and have action and side effects associated with the brain, like Benadryl. You get tired because Benadryl crosses the blood-brain barrier. Yes.
So, say someone has asthma, is there inhaler and antihistamine?
It can be antihistamine or it can be steroid, but it's local steroid.
Because my boyfriend, he has really bad asthma, especially this time of year. He has an inhaler he takes, and he takes a Zyrtec.
So Zyrtec is the antihistamine, and I take Zyrtec every day too. And it's probably one of the safest antihistamines that doesn't cross the blood-brain barrier. That's why Zyrtec doesn't cause you to be as drowsy because it doesn't cross the blood-brain barrier. Is it as effective as Benadryl? No, but it is effective. And so there are other ones too, like I can't remember what it's called, the drug ones, like Allegra or what is the Claritin? Yes, which if you talk to almost every doctor that's ever been alive, ever that knows anything about pharmacy, they'll tell you that Claritin doesn't work. It literally has been proven not to work. Don't take Claritin. Take Zyrtec. Cetirizine, take Zyrtec. Okay, so FYI. Allegra is hit or miss. It depends on the person. Okay. Yes.
Okay, let's say like you react to something like this, or like maybe I'm like after a couple of hours, do the symptoms kind of like fade out? Or
Yes. as the body, like once the mast cells degranulate, they're degranulated typically. And then can they reset and keep degranulating? Yes. But if you are eliminating the allergen in the process, like if you eat cheese and the cheese gets processed and eliminated from your body, it's done. You're done. Like once the allergen is gone. Does that make sense? And so once you're away from the mast cell. So if you eat cheese, you're causing your body to degranulate in like your small intestine, which is where that's where I have my inflammation, right? So I eat cheese, my mast cells in my intestines will degranulate once the cheese has been processed and isn't allergen anymore, because your body will digest the allergen, remember, because your body in your digestive juices are literally breaking down the proteins. We're breaking down the proteins. They're not the protein, they're not the allergen anymore. And so then you would stop having that inflammation once the body has broken it down. So it's usually kind of a short-lived response in that regard. And so with this situation with a bee sting, the bee injects the venom, the whole body is degranulating mast cells throughout your circulatory system. But once the bee venom is gone in your body, you'll stop having the reaction. And the whole point of the medical care in the meantime is to keep the inflammatory response decreased until the body gets rid of the allergen. So that's the whole point, is to try to get rid of that allergen that way. Okay. So antihistamines literally block the histamine itself. So it's a more targeted approach to the response, but they're usually only effective in atopic situations, local, not in anaphylactic. And anaphylactic, we're going to reach for epinephrine. Epinephrine is adrenaline, the same thing. If we're delivering it medically, then it is epinephrine. If your body is making it, it's adrenaline. The same thing, no otherwise, okay? If you are having an attack and you need to reach for an EpiPen, we deliver epi intramuscularly, IM, okay? And the dose that's given IM is at a dose that's meant to get into the bloodstream through the muscle tissue. You have to deliver it early. So if you are somebody that's allergic to shellfish and you start feeling the itch in your throat, and you're like, or you smell the smell and you know it's coming. Most of the people that have those types of allergies, they know their initial signs and symptoms. They start having the prodrome of their allergy, right? They start having the initial signs and symptoms, and they will get their EpiPen and deliver it intramuscularly right away. If they're having full on, their airway is already closed, EpiPen's probably not going to do a lot for them at that point. Why? Because they've already lost probably blood flow to the muscle tissue in their leg. And it probably can't deliver the epi effectively to the heart at that point, because it's already started closing off the vasculature to the extremities. So that can be a risk if you wait too long to deliver the epi dose. You don't want to wait too long. Somebody asked me in another of my classes, if somebody has an EpiPen, I was told that you can't deliver the EpiPen for them. Absolute falsehood. Okay? Absolutely false. If somebody's having an anaphylactic response and they have an EpiPen and they can't reach it and give themselves, give them the EpiPen shot.
Imagine watching.
Right? No, reach for it and grab the pen and give it to them. You'll pop the cap off and then and you put the plunger into their muscle. And it's important that you get it in the muscle, not in fat. So you don't want to go in the butt or the belly. It might be like, oh, it's close to their heart. No, 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 no. Into the muscle. It's made to go in the muscle. So as soon as you realize that they're having that response, into the muscle. Okay, that's what you want to do. EpiPens only last 15 to 20 minutes. The allergen will not be eliminated in that time. You must get them to a hospital. So if somebody is allergic to shellfish and you start having itchy hives, oh man, oh, I'm having a response. I need an EpiPen shot. Oh, I'm good now. Get back to work. No, because after that EpiPen one wears off in about 20 minutes, they're going to be having that response that response back again, and they might not have another EpiPen. Then what? Then they die, right? So once they have had to deliver the pen, they must be heading to the hospital or call 911 or something, so we can continue to give them help. Can they give another EpiPen shot if they have a second one? Yes, they can, okay? That's okay. But you want to keep in mind that this is only to buy you time to get you to the hospital where they can actually properly care for you. Once we get you to the hospital, we can give you intravenous epinephrine. And that'll be at a smaller dose because it's going straight to your heart. Okay? So the dose is based on the delivery method and your weight and your height and your like that sort of stuff as well. Okay. So there's that stuff. And that stuff that I learned, I know that the dose was different, but I had a paramedic in my class that had explained like the reasons why for it. And so that's the only reason why I'm able to tell you guys with as much knowledge as I do today.
Call 911 though. If somebody else has a pen, like you're having a reaction and I have a pen.
Yes, you could deliver your pen.
Yes.
Yes. Yeah.
No,
Yeah. Intramuscularly. right? So adult doses are usually adult doses. Then you have kid doses. Those are the intramuscular ones. But once you get to the hospital, they'll calculate based on your actual weight and stuff like that. Okay, any questions about epinephrine? Epinephrine is the same as adrenaline. So if we can get the adrenaline going in somebody's body, that's another way that we could treat it. Okay, so that'll open up the airways, it'll increase the blood flow and stuff like that to help reverse the histamine responses. All right, so this is multi-select. Which of the following help treat anaphylaxis? Anybody know what diphenhydramine is? Benadryl. Benadryl.
That's like a security, and then Claire's level security, right?
Yes, I think so.
Also take Pepsi.
I don't know much about that one. Yes, epinephrine and adrenaline on this one. So because epinephrine, obviously, that's going to be the medically delivered version, but adrenaline is the same thing. Are we going to give adrenaline to somebody? If we gave it to them, it would be epinephrine, but we can also increase their adrenaline response if we have other means to do that, okay? There's drugs that increase adrenaline production naturally. Okay, desensitization, we talked about this. If we can switch the body to making IgG, then the IgG will bind with all the allergens, so it can't bind with the IgE and cause mast cell degranulation. We can give you little doses of something. Okay, so we're switching to, that's it for type 1. Now we're in type 2. Type 2 responses are mediated by IgG or IgM, typically to the blood groups. There are 4 blood groups, A, B, AB, and O. There are other ones outside of this that are extremely rare that we're not going to talk about in this class. Okay? Like null. You might have heard of the null blood type. It means you don't even have the O marker. If you're a null blood type, you can't even receive O. You can only receive null blood. They're extremely rare. Okay. Yes, less than like 10 reported cases in history. So like we're talking very rare. It does exist, but people always ask me about it. It's always somebody, the null blood type, you ain't that, honey, so don't worry about it. Your patient ain't gonna be that either. The likelihood of that is so slim. So focus on our ABOs, okay? So these rely on your genetic types. A and B are both equally dominant traits. So if your genes, if you got an A from your mom, hold on. Yes, if you got an A from the mom and a B from the dad, you will be a B blood type. If you got an A from the mom and an O from the dad, you will be an A blood type. If you are an O and an O, you will be an O blood type. This is because O is recessive. You will only be O if you have 2 O alleles, so versions of the gene. So again, there's 3 versions of the gene, A, B, or O. If you have an A, you will express it. If you have a B, you will express it. So if you have both, you'll express both. O is like the default that all of us have in the background. I'll show you a picture of it, it'll make more sense.
So is A more dominant than B?
Yes, it is. Well, I don't want to say more dominant, more like more found in the population. Is that what we were asking? Or is like
If you have A, B, you would be A.
you'd be both A and B. You're A, B.
So they're equal.
Yes, they're equal. Yes, so A and B are equal. Yes, so okay. I'm glad we cleared that up. So here's the picture of it. This will make sense, okay? If you have an A gene, you will make A blood. You'll have this. So if you're carrying this gene, you'll have the A on you. If you're carrying a B gene, you'll have a B on you. If you're carrying both, you'll express both. Does that answer your question? Okay. This is O on the bottom. Okay, you see how it is the base that they're all supported on? If you have A, O is your framework, and you put the A on it. If you have B, O is your framework, and you put the B on it. But O is the framework. So we all see O as normal, as friend. It's not foreign to anybody. Okay? So we all see O as the base. If I am an A blood type, I see A as a friend and I see O as a friend because they both look normal to me. but you show me B, the yellow square here, you show me that yellow square, I'm gonna have a problem with that. My body's gonna see that as foreign and attack it. Okay. So now, take the step back. So now we're seeing this, okay? If I have A, I see B as foreign. If I have B, I see A as foreign. If I am AB, what do I see as foreign? Nothing. If I'm AB blood type, I see A as normal, I see B as normal, and I see O as normal. AB is the universal recipient. It can receive any blood type because all of it looks friendly. Now, I am an A. My sister is an AB. Okay? So if I get my sister's blood, what will my body do? Attack it because it has B. My body will see it as foreign. If she gets my blood, what will her body do? It'll be fine. It'll be fine, right? She sees it as normal. You see the difference there? Okay, she's AB positive. It's the best one to be. AB positive is the best one to be because you can receive any blood type ever. Okay, so we're only in the ABOs here. We haven't gotten to the positives or the negatives yet. Okay, this is just the ABOs. If you are O, what blood type can you get? O. You cannot get A, can you? You'd attack it. You can't get B. You'd attack it. You'd for sure attack AB. That's a problem. So O's can only get O. We tracking? Good. Okay. Okay. So here is a layout of that. There's a chart of this. If this helps for me, I look at charts and my brain just shuts off. But there is a chart of this that compares that. And I've seen in some people's concept maps that some people have their own charts made of all the different blood types and the reactions and stuff like that. Feel free to make your own. That's a helpful tool for you guys. Okay. But basically your genotype versus your blood type and whatever is listed on here. For the genotypes, I'm only going to briefly touch on the genotypes. Okay. My dad is a B positive. My mom, I don't know what her blood type is. Okay. She probably doesn't know either. She probably had it tested and she just doesn't remember. She's got to have an A in her body, right? Because I'm an A and my sister is an AB and she gave birth to us. So we know we're related to our mom. Okay. So if my dad was a B and I'm an A and my sister is an AB, my mom has to have A as a gene. She has to. Okay. So if my mom is an A something, I don't know what she's carrying on her other gene. And my dad's a B positive. He's either a B plus or a BB. Those are the two genes. He could have gotten one gene of B from his mom and one gene of B from his dad, and that's why he's a B. Or he got one gene that is a B and one gene that's an O. Remember, B and O, the B will be expressed, right? Okay, so we're going to start with the BB first. Really quick, this is called a Punnett square. You carry across and you carry down. Okay, so if we carry A down, A, if we carry B across, B, that would be one possible child. This next one would be a B something. This next one would be an A something, AB, and this one would be a B something. Could that be my dad's genotype? No. Why could my dad not be a BB? Because I'm an A. None of these possible children is an A. You see that? So that's how I know my dad's genotype. Even though he only knows his blood type is B positive, I know for a fact he has to be carrying B and an O. And this is why. Literally, this is why. If we erase all this. He's a B and an O. Now, if I bring this down, this is AB, this is BX, this is AO, and this is O, I don't know what. Whatever my mom was carrying, no idea. Because my sister's an AB and I'm an A. So I know my genotype too. It's a AO. Again, my blood type is A, but I know I have genes for O in there. I have to. So my husband is an O. I don't have kids, okay? But I know I'm an AO. We know this. If my husband is an O, what's his genotype? OO, it has to be, right? So if I had kids, they'd either be AO, AO, OO, or OO. I can only have kids that are A or O blood type. We tracking? Okay, so I can reverse it back and like see my possibilities I know I must be an AO because of my parents, and therefore, and my husband is an O, he has to be an OO if you're an O. Okay, so I could, if I had kids. Okay,
But
makes
he would
sense?
Be able to donate blood to you.
Yes, he's an O positive, and
Oh,
so,
oh, was that-
yeah, yes, he could donate to me, I could not donate to him. Right? Make sense? Okay, we tracking this? Because this stuff is absolutely key, right? This stuff is directly applicable. Now, we're talking about humans here. Do dogs have blood types? Yes, they have a lot. I think they have more than people do, I think. Yes. And so even this type of transfusion with dogs, if you are transfusing a dog, this stuff does matter. You can have some crossover with dogs, they're less likely to die from the type of mix of transfusions. But if you have a lot of transfusions in animals, like if you're giving a lot more blood to a animal while it's having a surgery or something, then matching is actually pretty helpful for helping the animal heal afterwards. And so that stuff can be helpful for that. And you might have seen even on like Instagram, so they'll put like stuff about like how you can have your dog donate blood or transfusions and stuff like this. This is a thing that happens. FYI. So this does apply to animals.
Squares get crazy with dogs because you can have like 2 chocolate labs
Mm-hmm.
and then you'll get black labs and.
Mm-hmm. Yes.
it's just-
Yes.
I don't know.
Yeah. And if so, this is like when this is Punnett squares, right? And so if you guys ever take a class on genetics, this is like, again, not even the tip of the iceberg with genetics. This is the basics. But there's other stuff involved. So I also want to talk about the commonness of the blood types in the population because people are just interested in it generally, and then we'll move on, okay? O positive is the most common blood type in the world. I already told you have to have 2 O's in order to be an O. A lot of people carry around O's though. Like I'm an A that's carrying around an O. And so half of my kids, again, it's 50-50. 50% chance I'll have an AO, 50% chance I'll have an O. So having the O and carrying the O, it gets carried around a lot. But I want to mention something in human history that will help you understand why O's are the most common blood type. And I mean O's are the most common, not carrying the O. O's are. O positive is the most common blood type. Why would that be? Because mosquitoes that carry malaria, common in what we would call the cradle of humanity, right? In sub-Saharan Africa, okay? Malaria is extremely common in sub-Saharan Africa. Type O blood is less likely to get malaria. So the survivability of people with O blood was higher. And so that increases the incidence. You see what I mean? So this is evolution. That's what evolution is. So that's probably why we see more O's in the population because it's a favorable trait to have for survivability in the face of malaria. Now, does that matter as much? Not as much in first world countries. But again, do we still have malaria? Is it still commonplace? Do people still get it all the time? Absolutely, just not here. So keep that reference, okay? So FYI with that, okay? So malaria is less common in O's. Now the mosquito population is also adjusted to this. Mosquitoes actually prefer O's. They can smell O's. And I can tell you that this is true. My husband is an O, like I said, and I'm an A. You put us outside, watch my husband get bit about 10 to 100 times more than I will. So mosquitoes can smell the O. So that's their like genetic like curve around that. So they prefer O smell. So they're more likely to bite the O's to accommodate for the spread of the malaria and stuff like that. So it's like a callback. You adapted, so you're less likely to get malaria, so I'm going to bite you more often. You're still going to get it. Like, I'm going to make sure. Like, that's basically like the callback to that. Okay? So that's where that probably comes from, genetically speaking. If you're B positive, you can get blood from anyone? No. Right. So if you're B positive, you can get blood from B positive, B negative, O positive, and O negative. Okay, we're going to talk about the positives next. So B's cannot get A's. A's cannot get B's. ABs can get anybody. O's can only get O's. We tracking? O is the universal donor. Exactly. So anybody can get O. Now we also have to factor in the positive and the negative. So when I say I'm A positive, we're talking about the RH factor. So I have the A for the ABO blood group, but I also have the RH factor. So this is if you have it or you don't. So if you're negative, you don't have it. To you, RH looks foreign. We also call it the D antigen. Okay, so negatives see positives as foreign. Positives see positives as friendly and negatives as friendly. It's like the base. Again, if you're negative, you just don't have it. And so anybody can get a negative. Negatives can go to positives and negatives, but positives can only go to positives. Again, so you have to factor in both the ABO and the RH, right? Okay, so if you are, this is really annoying, A positive, then you can get A positive, A negative, O positive, and O negative. If you are O positive, you can get O positive and O negative. If you are A, B negative, you can get A negative, B negative, O negative, and AB negative. No positives though. We seeing that? That makes sense? Okay. Oh, I don't know why I drew that like that. Okay, whatever, who cares? No positives. So again, if you are A, B positive, you can get A positive, A negative, B positive, B negative, O positive, O negative, AB positive, AB negative. You tracking that? So AB positive can get any blood type. AB positive, the universal recipient. What we will notice, what one do they all have in common? If you are O negative, you can get O negative. And that's it. And are we seeing that now as a problem? Because I told you O positives are the most common blood type, not O negatives. So is O negative the least common blood type? No, okay, it's not. Somewhere in the middle, okay? But anybody can get O negative. Let's say that we get bombed today. I know this is, I'm not trying to say that this is going to happen or anything. I'm not starting a thing, I promise. But let's just say it happens. Or a plane crashes right here on OSU OKC campus. And hundreds of people are injured and they need blood transfusions. Hundreds of people, let's say. Okay. What are we going to do if they all need blood transfusions? What are we going to give them? O negative. Because it takes 30 minutes to an hour to type and cross somebody. So if I don't know your blood type, I'm going to give you O negative at first and send your blood sample to the lab. And it's going to take 30 minutes to an hour to type and cross you. If we have hundreds of people needing type and cross done, it's going to take longer for that one person. I'm telling you, one person, maybe two. Baptist has 2 people in their blood typing lab. Southwest has 1. One person to type and cross. Hundreds coming in to that hospital. Okay, and we might be able to pull 1 or 2 other people to help them if we needed to. Like I said, it's a handful of people doing typing process. All right, and it's going to delay getting you your blood type. So if we have a whole bunch of people coming in that need blood transfusions immediately just to save their lives, we're going to give them O negative. Now let's say that something's happening where there's a natural disaster, where there's a big earthquake, or there's, Pompeii is exploding or something like this, okay? And a bunch of people are dying and they're continuing to get hurt and need transfusion. And it's all dying out. And so slowing down a little bit, we've had hundreds of people come in, we've been able to keep up with it. Now somebody comes in and they are O negative. And the only type of blood they can get is O negative. In a massive transfusion protocol, this is why we keep O negative on the shelves in as much numbers as possible. And if you ever hear that OBI is calling out for a plea for blood, it's because O negative supplies are running low on the shelves at Baptist, at Mercy, at wherever. And we need to get more O neg on the shelves. That's why if you are an O negative and you've ever donated blood, you will get lots of phone calls from OBI asking you to donate blood. Okay? Any questions about blood types? We're gonna move on.
In the video, you said that O negative, they would get fluids, just like an IV.
Yes, we will give fluids just to keep up the body's volume too. And so that will keep from having like a massive shock reaction, but you need blood to transport oxygen through the body, right? So at some point we have to give you red blood cells just to maintain transfer of oxygen throughout the body. But if you lose enough fluid, we can give you IV to keep up your fluids. You can also get plasma. Plasma has a lot of nutrients and things like that, including clotting factors and stuff like that that are in the plasma to help keep your blood volume up. If we start running low on red blood cells, that can keep you alive for a certain amount of time.
So plasma wouldn't have a type.
Right, and so plasma is a little trickier. There's more factors in plasma besides just, just liquid, right? And so there is a little bit of issue with some of the proteins that can be found in plasma that can lead to compatibility issues, but it's way less of a concern in emergency situations, yes. Plasma also is where we find antibodies. So like when we had COVID coming out, whenever we were talking about transfusing people with like antibodies from people that survived COVID, that came from their plasma. So that's where we'll get stuff like that from too. Okay, moving on. Yeah, okay, quiz question. Multi-select, select all that apply. What types of blood can somebody with B negative receive? You're B negative. It's only 2 of them. All right, so it's B negative, obviously, and O negative. O negative. All right. Universal donor is O negative. Universal recipient is AB positive. Yes. Okay. Next quiz question. Universal recipient. Universal recipient can receive anything. That's all right. Just rejoin if you want. So AB positive.
That's universal.
Oh, it is. Sorry, let me drag this out of the way. 832210. Yes. All right. Death is a common outcome of transfusing the wrong type of blood. So we're going to move on from this. If you're a mama and you are negative, you will see your baby's positive blood as foreign. So, for example, my husband's mom. Okay, all right, hold on. My husband's mom is O negative. This means that she has an O and an O, all right? And the dad also had an O and an O because I don't know for sure that he was O, but I'm not gonna do the Punnett square. She's O negative. I don't want to make this complicated when I don't need to. She's O negative, and my husband is O positive. So she's gonna see the positive as foreign. Why did it do that? Whatever. Okay, sure. She's going to see the positive as foreign. Okay. So her body is going to say, no, we don't want this here, and start attacking it. Now, the first baby that somebody has, the negative mama. It's only negative mamas. Positive mamas don't do this to negative babies, right? Because the positive mama sees the negative baby as friendly. The negative mama sees the positive baby as not friendly. Okay. So the negative mama makes antibodies to the positive baby in the womb. In the first baby, this is sensitizing. This is basically like when the baby starts making blood, which doesn't happen until later in the pregnancy. Okay. Once the baby starts having pluses on its blood, then the mama starts making the antibody and stuff like that. So the first pregnancy, we're just sensitizing. There's also something called the placental barrier. The mama can't attack the baby while we're pregnant and the baby's just growing. Can we make the antibodies against the baby? Yes, but they can't attack the baby yet. Once we start giving birth, the placental barrier doesn't hold anymore. So once we start going into labor, the antibodies can start attacking the baby. Okay, so the first pregnancy is usually safe, usually. But do we always know if that's the mother's first pregnancy? No, the mother might not even know. Remember, you can have miscarriages without even knowing, and many people do. So we don't know always. So almost always, if you are pregnant and you know that you're pregnant, we will blood type you. And if you are a negative blood type, we will administer RhoGAM whenever it gets close to you needing to deliver. Makes sense? So RhoGAM is an antibody that blocks the mama's antibodies. RhoGAM is an antibody that blocks the mama's antibodies from attacking. Okay? So that's the idea. So that's the idea with RhoGAM. Anti-RH immunoglobulins, so that the mama's body can't attack the baby. Okay? That's what RhoGAM does. If the mama's body attacks the baby, what's the most likely outcome? Death. This is not a joke. This is not a small thing. Now, if the mama is O and the baby is A, will the mama make antibodies against the baby? Yes. Well, I already told you, if I'm A and you transfuse me with B, I'll die probably. So if I'm A and I'm carrying a B baby, my antibodies will attack the baby, but it usually doesn't kill the baby with ABO discrepancy. That's how significant the RH factor is. It's big time talk, okay? So if I'm A and I'm carrying a B baby, I will make antibodies against my baby. More often than not, it will lead to some anemia of the baby. And that damage that's being caused by my baby's blood will lead to some issues with the liver that leads to release of bilirubin into the skin, and that causes yellow babies. That's why you have billy babies, why they have to go into billy lights. More often it's because of ABO discrepancies. But if you have RH discrepancies, that's most likely going to lead to stillbirth or death of the baby shortly after birth. And it happens still today. We don't catch that. Okay. And you probably know somebody or have had a class with somebody or will have a patient that will have this happen to them, even today, because we don't catch it. Especially if you're switching doctors, or that information doesn't get transferred
Is
over.
that not something they test for?
It is, but sometimes it gets missed if we have transfer of doctors. Let's say you're pregnant and you travel somewhere. And that doctor doesn't know, and you have, an emergency situation where you have to deliver earlier than you were expecting to. Stuff like that. You get what I'm saying? There's a lot of incidences that could lead to us not getting RhoGAM to the mother in time for whatever reason, or not even knowing that we could have this issue. Right, any other questions about this? This is called hemolytic disease of the newborn. Yes.
So would there be an instance where they could would giving RhoGAM when it's not needed cause bad effects too?
Mhm.
So why don't they just give RhoGAM?
So you have to give it early
I
enough.
understand.
Yes, and so it's not like an instantaneous thing. You can get some issues where you can give it even at last minute type of a thing where it can give some protection. And it might protect enough to protect from death of the baby. But again, it's usually something that has to be given not just immediately before labor. You know what I mean? So it just, and I don't know enough about the specifics of that stuff beyond the general application of it. So that stuff is worth looking into if you're thinking of going into OB or fetal medicine or anything like that. Yes, question? Oh, okay. Yeah. Yeah, so almost always if you're RH negative and they have any reason to suspect that you might be having a baby that could be positive, then they'll almost always give you RhoGAM whenever you're carrying. And sometimes I've had I've had students that have told me their doctor, oh, I didn't get RhoGAM. And I'm like, are you sure though? Are you sure you didn't? Because your doctors don't always tell you they're giving you RhoGAM either. It's just part of your protocol of treatments that you get as you're getting ready to have a baby. And you going into nursing now might have reference into what's going on with your body, but then you pre-nursing ideology might not have been paying attention enough to know that you did get RhoGAM, for example. Or some moms will be not knowing at all that even happened to them. So we're going to skip this question, but this is hemolytic disease of the newborn because we're already at 10:30. Anyways, type 3 is the immune complexes. This is where our antigen gets bound up with our antibody. These get stuck in our capillaries and stuff like that. And then neutrophils come and release, neutrophils see it and they're like, hey, there's antibody bound to antigen here. Inflammation, and it causes damage to the tissues where these things get stuck. We see this happening in blood vessels, especially in capillaries. In the heart and lungs, where we have small blood vessels that are feeding the heart and lung tissues, where we have exchange of oxygen happening. In joints, where tight spaces like the joints. In the skin, where we have small capillaries feeding the surface of the skin. And then in the kidney, where we obviously have toxin exchange happening in the glomerulus, right? Anybody in here taken anatomy and learned about the glomerulus or physio and learned about the glomerulus? Okay. In the kidney, where we have exchange of toxins, is a structure called the glomerulus. Nephro is the term for kidney. So this is why I'm bringing it up, because if you haven't seen the word, it's about to come out of my mouth, okay? Acute post-streptococcal glomerulonephritis. Okay, it's a mouthful. You think that, oh, glomerulus or nephro, this word, I'm never going to see it again. If you haven't taken anatomy, if you haven't taken physio especially, get that out of your head right now. So you're absolutely going to be seeing glomerulus over and over and over again. And if you think it doesn't apply to medicine, you're also absolutely ridiculously confusing yourself already. Like, it's definitely one of the most important systems of your body is how your kidney deals with toxins in your blood. And it governs so much of homeostasis, just in cycling out things out of your kidneys. So the glomerulus is where this happens, okay? Very small capillaries that are dealing with exchanges of toxins, gases, and basically soluble products in the blood, exchanging it across the capillaries in the kidney. One of the most important body functions that I could say. If it's not your heart and your brain, then it's your kidney. Like, that's how I feel about it. It's your heart, your brain, and then your kidney. Who cares about your stomach and your intestines? Let me tell you about your kidneys, okay? And so definitely big deal here, okay? So kidneys. So that's in your glomerulus of your kidneys. And nephro deals with kidneys. Okay, so glomerulonephritis, we have inflammation of part of the kidneys. And what happens is you get strep. The strep antigen binds with antibodies. That stuff gets cycled in through the kidney and gets stuck in your glomerulus. And then we have inflammation in that area. And this will cause kidney damage. This can be permanent, but usually temporary. For most otherwise healthy people, most of the time their body will be able to clear this out, but you will have inflammation and temporary kidney damage from this situation. Not everybody gets this from having strep throat, but this can happen. You can have kidney damage just from having strep and having the illness associated with having strep. Streptococcus pyogenes, group A strep. Okay, all right, nope, we're gonna move on. All right, type 4 hypersensitivities. These are interactions caused by T cells. These are our cytotoxic T cells. So when they get triggered, and they're going to attack those. We already had talked about one, which was our PPD test. Again, our memory cytotoxic T cells take 2 to 3 days to re-multiply up and then cause the reaction that they're associated with. They're delayed as a result of that. So whereas antibody-based immunities, like the type 1, 2, and 3 immunities, can be pretty much instantaneous for making the antibody and antibody reacting, these guys take a couple of days for them to show up. Okay, so they're delayed type. Reaction to the tuberculin skin test is called the Manitou test, also known as the PPD test. So we're injecting PPD, which is a tuberculin-associated protein, right under the skin. If your body welts up, that's because the T cells are attacking that stuff and they're remembering. And it happens within 24 to 72 hours, depending on the person and the location. This also is what drives contact dermatitis. So this is not atopic dermatitis like we saw with eczema. This is contact dermatitis. So anybody in here allergic to jewelry? It's a pretty common allergy, so I am too, right? Now, I like to wear jewelry. If I don't wear silver, gold, or stainless steel, I will have a reaction to it. So I'll wear cheapy earrings, and I can wear them just fine for a day. But the next day or the day after that, it'll get red and swollen and crusty and yucky. And that's because of my contact dermatitis to my jewelry, okay? So anytime you're having that weepy sort of damaged skin effect, that is a couple days after exposure to something, that is the same reaction as what we have with poison ivy. It's a couple days delayed. This is the delayed type reaction. This is the type 4 hypersensitivity, yes. Okay, this can be poison ivy, this can be jewelry, this can be surface contact to certain detergents and things like that. If you've ever had like a perfume or something that you've used, that's a new perfume, but a couple days, a day or two later, you get a rash from it, contact dermatitis, the delayed type hypersensitivity. All right. Yes.
So atopic dermatitis, eczema is class 1, contact dermatitis is class 4.
It's 4. Yes, exactly. And it just depends on what's mediating the response. If it's IgE and mast cell degranulation, again, that's going to be almost instantaneous. It's going to be within minutes of contact to the thing, you'll be having the reaction. But if it takes 24 hours to 48 hours, it's almost always your CD8 T cells in the type 4 reaction.
So like hives and things, are those under the umbrella of atopic dermatitis?
Yes. Yes.
It's not just eczema.
Right. Not just eczema, right? Hives and things like that. Yes. Yeah. All right. So this is how it works. We see our antigen, we activate our T helper 1 response, and the T helper 1 will initiate the CD8, and then we will start attacking our skin or whatever it is that's involved. Okay. So here we're talking about skin reactions. This is also what mediates graft rejection in transplant surgeries. So my MHC molecules that call out for help from inside stuff look like self. When they're just chilling on the surface of my cells, my body doesn't react to it. Your MHC molecules just chilling on the surface of your kidneys are just chilling. But when my body sees your MHC, because it looks like MHC, but different, my body sees it as MHC asking for help. So my body kills those cells. So in order for kidney transplants or lung transplants or heart transplants to work effectively, we have to make sure that your MHC looks as close to my MHC as possible so that my body doesn't reject it. And that's a T cell response, cytotoxic T cell against the MHC1. It's the #1 predictor of graft rejection. Okay? And again, it's a delayed response. And if it's the first time I'm seeing your kidney, we're going to start about rejection. It's going to happen like a couple weeks after the transplant, not immediate usually. Okay? All right. That's graft rejection. That's when the host rejects the graft. That's the typical situation. Now let's say that I need a bone marrow transplant. I have leukemia, so they irradiate my body and kill my bone marrow out, okay? And then I just take Barry's bone marrow and infuse it in my body again, and I replace mine with his. Should be fine, right? Except that his T cells might see my body as foreign. If his T cells see my body as foreign and his T cells attack my body, that's graft rejecting the host. So that's graft versus host. When the bone marrow, when the T cells from the donor attack the host, okay? So that's where bone marrow transplants make a difference. Or we have to match that. It's easier to match because there's less markers that we'll have to match for that, but still it is a risk both ways. So the only time the graft attacks the host is in bone marrow transplant. Otherwise, the host is usually attacking the graft. We tracking? Okay. There are 4 different types of grafts that we can put into major groups. Autograft, a graft from your own body, auto. Okay, it's auto like automatic, like it's auto from your own body. Okay. This would be like if you get a burn on your arm and you want to replace the skin with skin on your leg. We can put a little balloon in there, stretch out the skin, cut out the skin, tape it onto your arm. Should you reject that? No. Okay. Might you have healing issues or infections, of course, but not rejecting like this. Okay. Autografts are from self. It's the safest type of graft you can get. Isograft. This is from twin to twin. Could you have rejection issues from twin to twin? You shouldn't if you're identical twins, okay? Identical. You shouldn't. There might be training issues with how the body was trained during the immune development process that could differ from twin to twin. It could differ. I hate to break it to you, okay? Way, way, way less likely though. So it's the next safest. Allografts. This is from anybody who is not yourself or an identical twin. So even from my sister would be allograft, or from Barry to me, allograft. Doesn't matter how closely you're related. If you're not an identical twin or yourself, it's an allograft. Okay. Xenograft. This is from an animal to a person. This is heart valves from pigs or cows, for example. Okay. Xenografts. All right. Type 4 hypersensitivity, I know we're not going to cover this, but type 4 hypersensitivities like contact dermatitis and graft rejection involve the CD8 T cell response. Okay, so we're going to skip through this one. Autoimmunity is any time that it is self-attacking self. This can be due to any of those 4 categories. It could be type 1, type 2, type 3, or type 4. Here are some autoimmune diseases that are associated with various ones of these. We already talked about type 1 diabetes being type 4. T cell mediated. We talked about lupus and rheumatoid arthritis dealing with type 3. Unfortunately, rheumatoid arthritis isn't just type 3. It also can involve 2 and 4 also. It depends on the person, depends on their reactions and things like that. So these are all the different types that can be involved in different things. How do we trigger autoimmunity? Some pathogens look like us on their surfaces. And so when we start trying to attack the foreign and they look like us, that can lead immunity that attacks us. So that's molecular mimicry then. And we think a lot of our autoimmune diseases might be related to that. So something about having an infection leads to development of autoimmune disease. There's a lot of work being done on studying that. It also seems to be highly related to how your gut bacteria train your immune response. So gut biome seems to be a major player in how we are training our immune system and what could lead potentially to autoimmunity. Gut biome health. All right, immunodeficiencies, these are hyposensitivities. The primary ones are genetic issues. The secondary ones are ones that you get after the birth. No. Again, AIDS would be a secondary hyposensitivity. We'll talk about them, promise, okay? Secondary, not primary. So primary immunodeficiencies, things present like genetically in your body from the moment that you're conceived, basically. It's ingrained in your body. So this would be genetic issues. So you could have issues in your stem cells that lead to your B and T cells, for example. Those are usually SCID, severe combined immunodeficiency. It's combined because you're affecting both B and T cells, not one or the other. Okay. This can even lead to effects being wrong with your other leukocytes, not just your lymphocytes. So you can even have SCID that affects like macrophages and stuff like that. And somebody that has severe combined immunodeficiency, their B cells don't work, their T cells don't work, and some of their phagocytes don't work generally. Okay, so they're susceptible to all kinds of infection. They often don't live past childhood. There are different versions and different severities of SCID. Some of them are treatable with things like immunoglobulin infusions and stuff like that, and you can survive with some versions of SCID. There's the most severe type of SCID called X-linked SCID. X-linked SCID means there's an issue on the X chromosome. The X chromosome, one of the sex chromosomes, you have an X or you have an XX or you have an XY if you're a normal genetic human being. Okay, and if you have any more than just an X and a Y or X and an X, then you have genetic defect. Okay, that's how that works. Okay, so if you have an XX, you have two X's, you're female, genetically speaking, okay? However you identify is your choice. I don't care, that's on you. But if you are genetically XX, you have two X chromosomes, you have a backup X. Something's wrong with one of your X's, you got one that works for you. But if you're a male, how many X's do you have? One. So if there's something wrong on that X, you have no backup. So X-linked SCID happens in males. In order for a female to have X-linked SCID, there would have been a mom that carried the gene on one of the X's and a dad that had the disease. And these males do not live past childhood. So we do not see females with X-linked SCID because of that. We're tracking? So this is boy in the bubble. That's what this is. And it's not man in the bubble. There is no man in the bubble. Okay, the boy. Why is there no man in the bubble? Because the boy dies. That's the facts. Okay. Ain't no, Jake Gyllenhaal that's going to live to manhood and all that. Okay. It don't happen. So that's X-linked SCID. Severe combined immunodeficiency. So that's way early on. That's going to be here. That's going to be the development of the stem cells that lead to the white blood cells. That's SCID. After that, you could have development issues in the T cells. And I don't need you to know all the different possible disorders, but if we're affecting the T cells, keep in mind, if you're affecting your T cell development, your T cells are your captains that govern whether you can activate your B cells, right? So if you have a T cell problem, you've got a T and a B cell problem. So again, T cell issues are going to be worse than B cell issues, because at least if you have a B cell issue, at least your T cells work. Okay. If you have B cell issues, it's usually because you can't make antibodies or switch classes or something like that. So we call that agamma-globulinemia. Agamma-globulinemia means you don't make antibodies. Hypogamma-globulinemia means you make less than you should. And so we can give gamma globulin, which is immunoglobulins, from healthy people in their plasma to people that can't make their antibodies and give them some protection passively. And that usually will work pretty well for them. All right, that's the idea with the primaries. I'm going to click through them. We did those. Okay, now we're in the secondary ones. These are the ones that we acquire basically later in life. This can be from infection, like with HIV, or infection of your lymphocytes, like even with mono. You could have an issue with your lymphocytes from mono, for example. It's usually temporary, but it can result in that. HIV is probably the biggest one that leads to AIDS, acquired immunodeficiency syndrome. Non-infectious metabolic disease can decrease your B and T cell counts. Chemotherapy, often from cancer treatments, can lead to B and T cell reduction, and radiation, whether that's radiation treatment for cancer or radiation exposure from like X-ray exposure or gamma radiation, like if you went to Chernobyl. Okay, so that sort of stuff can lead to decrease of your lymphocytes. That would be acquired. We didn't have it from birth. Okay. All right, AIDS. We have HIV infection. It is defined by the number of CD4 T helper cells that you have. If you get below 200, you have AIDS. If you get below 200 of your T cell count, you have AIDS, and you're going to be getting opportunistic infections because your T helper cell count is not high enough to maintain the response against the infection. All right. I'm going to skip. Yes, AIDS occurs when our CD4 T cell count is reduced below a certain threshold. All right, cancers, again, can be associated with your lymphocytes, your leukocytes, and all sorts of stuff like that, leading to cancer development. And that's it for the chapter 17. That's just 17. We could get into 18. What I'm going to do is recommend that you guys watch the video for 18. Almost all of 18 is review. Almost all of it. There are a couple of things on 18 that are new, like Western blot and MALDI-TOF. So pay attention to those guys, look it up in chapter 18, but most of chapter 18 is going to be focusing on categorizing our tests. There are 4 major categories of the tests in that. I'm going to write them on here really quick so we have an idea of them, okay? So at least you have some reference. Let me get a darker color. Let's do this. We have, I wish I just had like a white background, not all this stuff, but it's fine, it's fine. Phenotypic. This is going to include things like our biochemical tests. Like, does our organism make urease? Does our organism make gelatinase? Does our organism ferment glucose? Those are questions about the biochemistry of our organism. And those are phenotypic. They don't rely on the genetic code being sequenced, and they don't rely on antibody or antigen. So phenotypic. These will include biochemical tests, stains, our selective and differential media, it'll also include certain types of Kirby-Bauer tests. Now, I want to be very clear about the Kirby-Bauer part of this. Remember Kirby-Bauer, we used it to determine what antibiotic we should use to treat our infection. If we do that way, is that a diagnostic test? No. Are we using it to diagnose what is causing the infection if we do that way? No. So it's not always a diagnostic test. Some types of bacteria just are resistant to certain antibiotics, and that can be used to diagnose. So it's very rarely used that way, but it can be used. That's why I have it in parentheses, okay? This also includes phage typing. I'm gonna write phage like this, phage typing. This is because there is a bacteriophage. Let's call it the 894. I don't know what it's called, doesn't matter. 894 phage infects salmonella, and it only infects salmonella. You get a patient that has diarrhea, you culture up their diarrhea, you infect it with 894 phage. If the 894 phage kills your patient culture, then your patient has salmonella. If it doesn't kill the patient's culture, your patient doesn't have salmonella. So we can use whether that phage, the virus that infects bacteria, we can use that to diagnose as well. So that's phage typing. So those are examples of phenotypic. We also have immunologic. This is anything that has to deal with antigen. Usually it's going to be antibody and antigen interactions. This includes ELISA. It includes immunofluorescence. It includes immunochromatography, those rapid tests that we talk about, like pregnancy tests and home COVID tests of immunochromatography. So those are all governed by antibody antigen. When we talk about the PPD skin test, we talked about being a type 4 hypersensitivity, right, to tuberculin protein. That is an in vivo immunologic. Does it rely on antibody? No. Does it rely on antigen responses? Yes. From the cytotoxic T cells. So we're still relying on antigen. We're still relying on the immune system. Relies on an immune system response. It's immunologic. These are either going to be indirect or direct. That term does not just apply to ELISA. It applies to all immunologic tests, immunofluorescence, or anything. If we're testing for antigen, direct. We're testing for antibody, indirect. We're tracking? Okay. Then our last major group is the genotypic. It's phenotypic 2. So I'm writing it off to the side so we can see it. 3, genotypic. Genotypic is looking at depends on the genetic sequence of the organism. This includes PCR. Again, what is PCR? Amplifying DNA sequence. You're using a primer. If the primer binds, then you can elongate. The primer must bind in order for you to elongate. So it depends on that primer binding. If it doesn't elongate, the primer didn't bind, you are not positive for the sample. That's PCR. DNA like multiplication, amplification. PCR, nucleic acid hybridization. We did talk about this. Here we use probes. And here basically like we say that this sequence of CCCTAAGT means that if you have this sequence present in a bacteria, you must be strep. So I could take a swab from your patient's sample or from their wound or whatever, their throat, whatever, put it on a slide and see if this linked to fluorescent probe. What was that noise? Okay. So if we have this probe that glows green and it sticks to your patient's sample and your patient's sample glows green, then your patient has strep. This is based on the genetic sequence. So you guys might be thinking, yeah, if you have an antibody that binds to the surface protein of strep and it's linked to fluorescent, that's immunologic. But if you use the DNA sequence to look for it, that's genotypic. So nucleic sequence or antibody, both can be linked to probes. Which one is linked to the probe, the DNA sequence or the antibody? And then that's how we categorize it as immunologic versus genotypic. And you must be able to categorize our tests. That's the biggest take-home message of chapter 18, categorizing our tests. Oh, there's one more test in immunologic that you need to know that is new to you, and that's the Western blot. I'm not going to go over it here, but you need to be sure you know about it. There's a video of it. I explain it in the lecture, all sorts of stuff. It's taking, remember how in ELISA, we basically like took the patient sample, and if the antibody binds, then the enzyme cleaves the thing and causes the color change, right? It's pretty specific. It's pretty sensitive. But let's imagine there's something that looks like the protein in there that might cause it to turn positive. What if we could make it more specific? Even more specific. That's what Western blot does. We're taking all the proteins in your patient's nasal swab, separating them out in a gel based on size, just like we do with DNA, but with proteins this time. Transferring the separated things to a paper, and then seeing if the antibody binds to that. If it binds to the right size of protein, now you know it bound to the right thing and not just something that looked like it. Okay? Okay. That's Western blot. It's gel electrophoresis of the proteins and then seeing if the antibody binds. Okay, so if you want a video of it, there's one in the lecture for it. All right, back to the genotype stuff. This also includes microarrays. This is a lot like nucleic acid hybridization, but with a plate of a whole bunch of sequences. So I can have a plate with 365 different things on it, and in each spot, a different probe. A probe for strep, a probe for E. coli, a probe for staph, a probe for something, something, something. Put your patient sample on there. Wherever it binds, then it's positive for that thing. If we use this for infections, we can also use it for genetic issues. So if we're looking for markers of specific mutations, we can use like amniocentesis to collect a sample from a patient's womb and then see if it mixes on the microarray. And if it does bind to any spot, that would tell you that your baby might have these genetic abnormalities. You can use it for different types of cancer. You have breast cancer, but how many types of breast cancer are there for different mutations? So I can do a microarray to see which mutation that the patient has, for example. So that would be an example of that. And then there was an other category. In the other category was imaging. You're doing X-rays, CT scans, stuff like that. That's in the other category. And there was one more other that you do need to know, and that is MALDI-TOF. Again, this is in the other category. MALDI-TOF. Oh my God, got it. In MALDI-TOF, it's a mass spectrometry and it measures the time of flight. That's what TOF stands for. I'm not going to ask you what MALDI-TOF stands for, but you should have an idea of what mass spectrometry is. And you should have an idea that we're measuring the time of flight. So what happens in this and how does it work? A laser, we get the patient's sample, whatever, we swab their nose, who cares? We shoot a laser at it and it causes particles to fly off. And then a sensor measures the time of flight in the chamber of all the particles that are coming off. You can imagine it's going to break down the particle and it gives a signature of different particles coming off at different times, how long they're flying in the chamber, measures the weight of the molecule and all sorts of stuff. And then we get this profile of these spikes of when the molecules hit the detector. And then based on that profile, we can tell you exactly what that molecule is.
Don't they identify what outer space gases?
Yes, yes. So mass spectrometry does that, like by literally breaking down the particles and measuring them as they come off and meet the detectors. Okay, so it's very physics-based. Yes, it's really cool. So we can use this to diagnose pathogens. We can also use it to diagnose what drug is in your patient's bloodstream if they're ODing. Now, it's not cheap, right? But it can be used to diagnose that stuff too. So if your patient is ODing and we need to run that, it's not fast either. So it's not like instantaneous. It takes a while for the process to complete. But it can be used for stuff like that. If you're not sure what's going on in somebody's body, you can molecularly break down the molecular makeup of it, and it's very reliable for that type of thing. Okay, and that is it for chapter 18. We'll head up to the lab now. I'll give you guys 10 minutes. Meet me in the lab in 10 minutes, and we should be good to go.